Prynawn da, Naomi Marfel, rheolwr Canopi dwi ac mae'n pleasure ei croesawu i symposium blynyddol Canopi. Bydd y symposium eleni yn canolbwyntio a ffiniau ymchwil mewn iechyd meddwl a lles. Good afternoon, I'm Naomi Marfel, Manager of the Canopi Service. Welcome to our annual symposium. This year's symposium will focus on research frontiers in mental health and well-being. Yn gyntaf, rhywfaint o wybodaeth cyffredinol, gan taw webinar yw hwn, nid fy modd ei gweld yn ystod y cyflwyniadau a bydd ein microffon yn cael ei diffodd yn awtomatig. Yn ystod y cyflwyniadau, defnyddiwch y bocs sgwrsio i gyfrathebu ac i ofyn unrhyw cwestiynau. A bydd cyfle ar ôl bob sgwrs hefyd i godi ei llaw a gofyn cwestiwn. Mae gen i nifer o siaradwr heddiw a fydd yn siarad am wahanol datblygiadau mewn ymchwil ym maes iechyd meddwl. Yn gyntaf, rydyn ni'n falch iawn o'r gael neges groeso gan Sarah Murphy, ein weinidog iechyd meddwl a llesiant. So firstly, some general housekeeping. As this is a webinar, you won't be visible during the presentations and you're automatically muted. If you'd like to ask any questions during the presentations, you're welcome to pop those in the chat box, and there will be opportunity after each talk to raise your hand and unmute and ask your question in person if you would prefer. We're really pleased to have a number of speakers with us today who are going to be talking to us about different advances in research within the field of mental health. But firstly, we're delighted to have a welcome message from Sarah Murphy, the Minister for Mental Health and Wellbeing, which we will play now. Thanks, Caitlin.
Thank you very much for inviting me to join you today. It is a real privilege to be part of this symposium, bringing together people who are united by shared commitment, supporting the mental health and wellbeing of our NHS and social care workforce across Wales. And I'd really like to begin by acknowledging everyone, clinicians, practitioners, researchers, academics, and those with lived experience. And I would also like to thank all of today's speakers and contributors in advance for the knowledge, insight and expertise that they will share over the course of the symposium. The information, evidence and reflections that you impart today are vital in helping us deepen our understanding and improve the way that we support our workforce. And I also want to pay tribute to the Canopi team themselves. Canopi has become a vital source of support for those who care for others every day, and its success is a real testament to your dedication, professionalism and compassion. Our NHS and social care work is truly the backbone of public services in Wales. Every day, staff show extraordinary resilience, skill and kindness in the most demanding of circumstances. They care for people at their most vulnerable, often while managing heavy workloads, emotional pressure and the cumulative impact of stress and trauma. The COVID-19 pandemic shone a stark light on this reality, but the truth is that pressures on the workforce existed long before, and they do continue today. It is therefore both right and necessary that we place the mental health and well-being of our workforce at the centre of our priorities, not as an afterthought, but as a fundamental part of delivering safe, compassionate and sustainable care. Canopi represents exactly the kind of proactive, compassionate approach that we need. And as a free and confidential mental health service for NHS and social care staff in Wales, Canopi removes many of the traditional barriers that prevent people from seeking help. It is accessible, trusted and tailored to the realities of working in health and social care. The fact that Canopi is so well utilised tells a very important story. It tells us that when we create the right conditions, when support is easy to access, stigma is challenged and confidentiality is respected, people will come forward. That is not a sign of weakness. It is a sign of strength, self-awareness, and also real professionalism. Welsh Government is proud to fund Canopi, and we remain committed to ensuring that services like this continue to be available, sustainable, and responsive to need. Alongside the delivery of high-quality support, research and evidence play a crucial role in shaping effective mental health services. And research also has a powerful role in destigmatising mental ill health. By grounding conversations in evidence, we move away from myths and assumptions and towards understanding, empathy and informed action. The work being shared at this symposium, whether research findings, service evaluations or insights from practice, is essential in building a stronger, more resilient system. And I want to thank all of those involved in generating and sharing this knowledge. Your work helps ensure that policy, practice and funding decisions are informed by evidence and that real-world experience. Despite progress in recent years, stigma remains one of the biggest barriers to people seeking support. This is particularly true in caring professions, where there is often an unspoken expectation to cope, to be resilient at all times, or to put others' needs before your own. For too long, mental health has been treated differently from physical ill health. Experiencing anxiety, depression, burnout, trauma is not a personal failing. It is part of being human, particularly in emotionally demanding roles. By openly talking about mental health, by sharing research and lived experience, and by visibly supporting services like Canopi, we send a powerful message. It is okay to ask for help, and it is okay not to be okay. Destigmatisation does not happen by accident. It requires leadership, commitment, and that cultural change at every level of our organisations. Leaders play a critical role in setting the tone through the language they use, the behaviours they model, and the priorities that they champion. Creating psychologically safe workplaces where staff feel able to speak up about their well-being without fear of judgment or negative consequences is essential. But culture change is not just about senior leadership. It is about teams and peers and everyday interactions. It is about checking in with colleagues, listening without judgment, and recognising when somebody may need that support. Services like Canopi do not replace supportive workplaces. They complement them. Together they create a system where well-being is embedded, informed by evidence, and continuously improved through learning and research. The Welsh Government is clear in its commitments to improving mental health and well-being across Wales, including for our workforce. And our investment in Canopi reflects our belief that prevention and early intervention are not only the right thing to do for our individuals, but it does also make sense for our public services too. Supporting staff well-being helps with retention. It reduces sickness absence and ultimately improves the quality and safety of care for patients and service users. So I want to briefly acknowledge the importance of lived experience in shaping services and conversations around mental health. Hearing directly from those who have access support, including Canopi, is one of the most powerful ways to challenge stigma. Personal stories, alongside research and evidence, helps us understand the real impact of our decisions. They remind us that behind every service is a person, and behind every person is a story that deserves to be heard with respect and compassion. In closing, I want to thank all of those, again, contributing to today's symposium for the expertise and insight and evidence that they will share. The learning from today will help really inform future practice, policy and services. Caring for others should never require sacrificing your own well-being. A healthy workforce is not a luxury, it is essential. So let's continue to normalise conversations about mental health, to learn from evidence and experience, and to build services and workplaces where asking for help is seen as a strength. Diolch yn fawr.
Thank you very much, Sarah, for that welcome message. Diolch yn fawr iawn, Sarah. Nesaf, dyma Dr Thomas Kitchen. Mae Thomas yn anaesthetig ymgorol ac yf gyfarwyddwr Canopi. Bydd Thomas yn siarad am wasanaeth Canopi a'r gwaith i cefnogi staff yn gwasanaeth iechyd gwaddol a gofal cymdeithasol yn Gymru eleni. I'll now hand you over to Dr Thomas Kitchen. Thomas is a consultant anaesthetist and co-director of Canopi. Thomas will provide a service update and further information about Canopi and reflect on its work to support NHS and social care staff in Wales this year. Thanks, Thomas.
Naomi, thank you very much for the introduction, and good afternoon, everybody. I'm just going to share my screen and hopefully we can carry on. So, our annual symposium, first of all, thank you for joining us this afternoon. It's really important to us to see so many people here and have the opportunity to share some news about Canopi in its first instance, but also more generally in terms of the interests of Canopi, in terms of research and projects that are going on that we've put together as the presentation of the symposium for today. So let's start with a little bit of information about Canopi. Hopefully this is known to many people, but Canopi is a confidential and free integrated mental health support service for the NHS and social care staff working in Wales. You'll see by, I guess, some of the branding on the slide, we are hosted by Cardiff University and we're funded directly by Welsh Government. The critical thing that Canopi represents for us is this bringing together of both health and social care and making sure that our offer is as equitable to both of those groups of staff as is possible to create in a service here in Wales. We've already mentioned the first bit of this slide in that we're here primarily to provide a confidential space to discuss mental health concerns for all of this staff group. But specifically, I guess our purpose and our aim is to support those people who experience specific barriers to disclosure. And those barriers can be broad and wide, or they can be very specific in terms of the challenges that people face in talking about their mental health concerns. But we're here to support you, particularly if you feel like there is nowhere else to go, nowhere else to talk to, or you're worried about disclosing that conversation to somebody else. What does the service look like? How does Canopi function? Well, we're a self-referral service. We don't accept referrals from other organisations. We encourage those people who would come to the service, who we call clients, to fill in a web form. If there's challenges around that, then there are people supporting a help desk to speak and talk people through how they might fill in that form. So filling in a web form and then given the opportunity to have an appointment with one of our doctor advisors. The point of this particular interaction is to create that initial safe space, to make sure people feel that they've had their opportunity to tell their story and it's been listened to. And after that, then we go on to signpost people towards various different aspects of the service so that we can support that disclosure. What do those different aspects of the service look like? Well, the first on this list is our wellbeing allies. Our wellbeing allies come from various professional backgrounds with some experience across health or social care, and they're volunteers, and they're volunteering to create safe listening spaces for people to continue that conversation and build those stories with somebody that they can trust and decompress and share their emotions and their concerns. We move on then to talk about self-help. There's a lot of self-help material around, isn't there? But I guess the particular advantage here is that having had that conversation with one of the doctor advisors, there's the opportunity to direct that self-help, to direct that information in a very specific way to that person's challenges and difficulties. We also then move on to other forms of support in terms of guided self-help. We are running a therapist guided CBT program that I'll come on to talk about more briefly in a few moments' time. We support onward signposting to Silver Cloud and to a program called Spring, which is a PTSD focused CBT program. We also offer virtual therapy and in a small number of cases face-to-face therapy with BABCP accredited therapists. And as people come to the Canopi service, then people are screened for alcohol use disorder, recognising the overlap between alcohol and substance misuses and mental health presentations. So that's, in summary, what the service achieves. Who comes to the service? Lots of people come to the service, and we'll come on to describe how the service has grown in a couple of slides' time. But I wanted to put this slide up in particular. This is a graphic taken from our annual report of last year to just describe, I guess, the breadth of people, the breadth of backgrounds that people are coming to the service with. They're also coming from every health board in Wales. They're also coming from every geographical area that's represented by our social care services in Wales. And that's something we're really proud of, I suppose, as a service, in that hopefully wherever you are in Wales, there has been the opportunity to hear about Canopi and to seek out support if in those moments of time that you need it, it's there for you. Well, once you come, how do we support the people that are coming to the service? In the year ending in 2025, financial year ending in 2025, we'd supported over 3,500 people to come to the service. We'd had nearly 150,000 visits to the website, nearly 2,000 people signposted and supported through cognitive behavioural therapy. And you can see from the other numbers here, the other support services, so nearly 150 people supported by our wellbeing allies, 71 people to the specialist PTSD support through Spring, and 600 views of our blogs, which range from personal stories through to opportunities to, I guess, in a very light way, access some of that psychological material that might help us build some of that consciousness about how we can help, how we can be informed, and maybe support other people that are around us as well as ourselves. We mentioned service growth. It's a relatively complicated graph, so apologies for the complexity, but we build it up from the bottom line, which is year one of Canopi. This is reflecting on the fact that Canopi existed before the year one of Canopi as Health for Health Professionals Wales for many years. Initially, prior to the pandemic, seeing approximately one person per week. And then as we came through into the pandemic, that number increased and has continued to increase year on year since. We're now in Canopi year 4, which is the dark blue line predominantly at the top of this graph. So we can see year 1 in blue, and then year 2, 3 and 4 in the progressively darker green lines as we move up the graph. The use of the Canopi service continues to increase, and we're now running at an average of approximately 80 referrals or over 80 referrals a week, as you can see from this graph. There's some seasonal variation in that, but the overall trend is up, and that's mirrored not just in our experience here in Canopi, but in other services. So NHS Practitioner Health in England and the Scottish Specialist Service in Scotland. A continual growth of people reaching out for confidential non-employer based services to share and disclose their mental health concerns in the expectation that there's something at the end of that conversation to support them through the challenges that they're facing. What do people think of Canopi after they've been? Here we see, I think, some remarkable data given the numbers of people coming to the service. 90% of clients found their interactions with the Canopi help desk, that initial team, helpful or very helpful. 90% of people found that their interactions with their doctor advisor was helpful or very helpful. 81% of people found that they got all or most of the help that they needed from accessing the Canopi service. And 89% of the clients who came to the Canopi service would be likely or very likely to recommend the service to other people who were in need. And I think we just need to reflect on the fact that this data is presented in contrast to a mental health support system outside of Canopi that is delivered by the NHS that is very under-resourced. The challenges that people face in accessing mental health support outside of the Canopi service, outside of employer-based services, is extremely challenging. I want to just touch on a little bit of service innovation that we've been working on, I guess, in the last year or so. Recognizing that we had increased service demand and recognizing that the changes, I guess, in some of the client needs as they were coming to Canopi, and then taking the opportunity to compare our models with other models and combine our learning with the research that we're in touch with here in Cardiff and more widely. Well, we recognize that actually our model that was predominantly CBT based at the time, in terms of an 8-session model with a BABCP accredited therapist, was probably not meeting the needs of us as a service, nor our client base who are coming through to the service. That led us to develop what we've described as therapist guided CBT, which from a Talking Therapies NHS England perspective, you might recognise as being similar to a step 2 model of CBT delivered by psychological wellbeing practitioners. And what we created was a tested and tried system where we took clients for an hour's assessment and then supported them after that hour with 4 30-minute sessions with supported self-directed work in between and phone calls between those specific sessions. So we built on, I guess, the NHS Talking Therapies model, combined it with these touching base phone calls that we'd seen being really successful in the spring intervention that was introduced by Cardiff University, and used that to create a service that is the only nationally delivered step 2 PWP-led service in Wales. So we are able to innovate, I guess, in this space and use the opportunities that the clients that are coming to us present as a way of developing not just a small, niche, localized service, but something that can deliver on a national scale, and hopefully therefore support the mental health of the workforce as they continue to deliver their service to our population. What about the outcomes for therapist-guided CBT? Well, again, I think there's something here really to be quite proud of. So by definition, the concept of reliable improvement and reliable recovery are defined as measures of metrics for the IAPT services, the talking therapy services in NHS England, to be measured by. A reliable improvement shows that a patient has shown reliable improvement if there's a significant improvement in their symptoms following a course of treatment. Reliable recovery combines two ideas, the idea of recovery and the idea of it being reliable, and the patient in this situation has a reliable recovery if they meet the criteria for both recovery and reliable improvement that we've just put there on the screen. 82% of clients who come to a therapist-guided CBT module or program as part of Canopi had recovered. Now, the standard set for NHS England for the talking therapy services here is 50%. So Canopi in this program is outperforming the baseline measure that would be expected of a talking therapy service. Now, that's, I guess, a fairly easy metric to measure. What I'm particularly interested in is that 67% of people saw a reliable improvement in those symptoms, and 68% of people show a reliable recovery. These interventions, even though they are short and they are focused, are effective. They're effective at creating reliable recovery for the working group, for the group of people that are coming to Canopi. So that's a really short, I guess, slide set presentation relating to some of the experiences of Canopi over the last year or so. I wanted to finish with two things. The first is a recognition of the ways that we are able to help, and the last one is to reflect this back into a story of one of the clients that has come through the service. So can you help? Absolutely, we can help. There are many ways that we can help support the mental health and well-being of our NHS and social care staff. We can do that individually in our workplaces by creating safe spaces for people to tell stories, providing peer support, and recognizing that it's okay in work to not be okay, and trying to normalize some of the stigma around talking about mental health. It's critical because at the end of the day, this needs to be a population workforce-led approach. From a Canopi specific point of view, how can you help? Well, we've already mentioned the first group of people here in terms of their activity relating to the Canopi service, and that's our wellbeing allies. So if you or your colleagues or people that you know within the workplace have got the opportunity to have time to be able to spend some time listening and supporting people that might come to the Canopi service, our colleagues at the end of the day, then please do get in touch with us. We would love to hear from you. The other group that we're keen to work with over 2026, looking forwards, is our group of people who have lived experience. We're keen, as we've hopefully demonstrated, that Canopi continues to develop, that we continue to grow and innovate in this space, that we might provide the best quality service, and that we might be in the right space to provide the right things for what this workforce needs. The only way for us to do that really is to hear back from people, to hear their feedback, to hear of their experiences, not just with the Canopi service, but with other services that are available to people in Wales and more widely. So again, an opportunity to share some of that experience, and if you're interested, then please do get in touch. This is a quick snapshot of the Canopi website. The Work With Us section is at the moment within the Contact Us tab. So click there, click into Work With Us, and the opportunity to get in touch and for us to have a conversation about how you might contribute to the service. Lastly, I wanted to draw our attention to a story. This is the story of a Canopi client. So I'm just going to move that out of the way so I can read this. And I'd like to read through some of what has been summarised here in a blog that's available on the website. So, in my current role within a safeguarding team, I deal with some complex cases which contributed to me having overwhelming feelings of stress in 2023. At the time, I didn't feel able to speak to my manager about this, and I avoided going to see my GP, afraid that they might sign me off work, resulting in increased pressure on my colleagues, not to mention the unwanted attention that it would bring. I wanted to find a way to manage my work stress so I could stay in the safeguarding team but avoid falling back into the cycle of panic that I had experienced before. The help that Canopi provided was massive. I struggled to put into words how much it helped me to continue working in my job as a social worker. Since my sessions with Canopi have come to an end, I am able to better manage stress and reuse the activities recommended by my therapist to support me to do that, help me to do this. I've confided in 2 colleagues about how the service has benefited me and that it has had a much more positive impact than going off sick would. I can only thank Canopi profusely for their help and hope that this blog is helpful to anyone feeling stuck. So I finish on that note. I'd like to say thank you to everybody that's contributed to Canopi in the various ways that they do, and leave the last shout out to Joanne and the message that this blog presents, which is hopefully, as we come to experience positive interactions around disclosing of mental health, whether that be through the Canopi service or through interactions with our colleagues, then we might talk about that. We might talk about that to other individuals. And in talking about it, we might normalise it. And in normalising, we might destigmatise having conversations around mental health in the workplace among our health and social care colleagues. So thank you very much for your time today. I'm going to ask if there are any questions that people would like to raise. In the absence of questions, Naomi,
I was going to just say exactly the same thing. Thank you very much,
I'll
Thomas.
hand back to you.
Diolch yn fawr, Thomas. Nesaf, mae gennym sgwrs gan Alison O'Connor o'r enw Nid wrth arfymen fy hun. Mae Alison yn cymradd Churchill a chyd sylfaenydd Moral Injury Partnership. Bydd Alison yn cyflwyno canfyddiadau werthusiaid o ymagwedd grŵp at anafiadau morsol. Thank you, Thomas. Next, we have a talk entitled I'm Not Alone by Alison O'Connor. Alison is a Churchill Fellow and co-founder of the Moral Injury Partnership. Alison is going to present some findings from an evaluation of Reflect and Renew, a group approach to moral injury in frontline professionals. And Alison, if you're ready, I'll hand over to you. Thanks very much.
Thanks very much, diolch yn fawr. Could you just let me know if you can see my screen?
Yeah, all working fine, thank you.
Perfect, great. Hi everyone, really pleased to be here. Thank you so much to Thomas and the team for the invitation. So yeah, I'm going to share the findings from Reflect and Renew, which is a group intervention for moral injury across frontline professions. So I'll share a tiny bit as part of this about moral injury, but I guess I'm going with the assumption that probably now most of us are quite familiar with that term. Just checking that yeah, there we go. So 10 years ago now, in 2016, I was fortunate to receive a Churchill Fellowship to travel around America and also to go to Sarajevo in Bosnia to look at how creative approaches to trauma recovery were helping people who'd experienced conflict in a military context and also in a community context. So when I went on my fellowship, I thought I was going to be talking about and listening to stories about post-traumatic stress, trauma, and actually the core discovery was, which to me was completely new then, this emerging construct of moral injury. And my experiences there, I was sort of immersed in projects and programs where storytelling, theatre, songwriting were being used alongside more clinical approaches to help people explore and reflect on really difficult experiences. And for the last 10 years, lots of my work has been in this area, and I believe strongly that creative communal approaches are really key to us deepening our support for the moral well-being of ourselves and others. So moral injury is from Brett Litz and colleagues, the sort of definition is the deep emotional and psychological distress that arises when we witness, carry out, or experience acts that violate our core moral values. And a lot of the early research was done in the military context. This idea that when our core sense of what is right is damaged, it impacts us in a profound way. And Edward Tick, who's an Indigenous psychotherapist, referred to this as a soul wound. So Jonathan Shea was a military psychiatrist working with Vietnam veterans, and he gave us the term, the concept moral injury, as we understand it now. And what he and his colleagues working in the 80s and the 90s with Vietnam veterans, what they and the veterans themselves kept noticing was that while for some people, trauma therapy, talking therapy, sort of cognitive approaches were helpful, certainly in terms of reducing the fear response and, trauma flashbacks, there was a huge amount of need and distress that wasn't being met. And through a lot of reflective conversation, Jonathan Shea arrived at this idea that actually the biggest thing people coming back from Vietnam were struggling with was a sense of wrongness and a sense of moral violation, particularly in terms of a betrayal. He uses this phrase, a betrayal of what's right in a high stakes situation by those in authority. So this sense of a trust being broken, a social trust. So keep this in mind, because I'm going to move to its relevance to health and social care in a moment. The key point I want to make here is that and this is from many decades of research, practice, reflection, from people who were trained in very much in a medical model, psychiatrists, they arrived at this conclusion that the cohort of Vietnam veterans had been subjected to decades of suffering due to a lack of opportunity to communalize their grief. So I think that's just ask you to sort of hold that in mind for a moment, that phrase. So moving on then to health and social care, moral distress, moral injury have been acknowledged and talked about in health, social care and the military way before the pandemic. But the pandemic absolutely has sort of catalyzed our recognition of this in health and social care. And this phrase here, as with soldiers in war, we know that when we stop doing, we're going to start feeling, was written by Wendy Dean and colleagues. They're a group of health practitioners in America, and they published this article in the wake of the suicides of 3 of their healthcare colleagues in the first wave of the pandemic. And that's really significant because since then there's been a lot more research emerging about the link between moral injury and suicide. So it's really, important that we do acknowledge that. But the reason I mentioned their article is they made a plea in it they said, once the pandemic is over, we, as in the health and social care workforce globally, are going to need time and space to process the losses and the trauma of the pandemic. I'm sure probably most of us here in this room know that for most health and social care workers, that time and space never came. I know from my work listening to lots of healthcare professionals and social care that, for many, that if anything, the context has become even more difficult. So just moving on there. So within Wendy Dean, who I mentioned there, she has gone on to create an organization in America called Moral Injury in Healthcare, which is doing fantastic work around awareness raising and working towards culture change. And one of their key components, which our program Reflect and Renew has been driven by, is differentiating burnout and moral injury. So burnout tends to be seen as an individual issue, perhaps due to lack of resilience or, you know, not good enough coping. Whereas moral injury, for me, one of the really compassionate elements of moral injury is that it acknowledges the systemic nature of suffering. And that actually it's a very human response to working in sometimes, unfortunately, inhuman contexts and situations. So in a survey of doctors by the BMA, this was back in 2021, 78% said the terms moral injury or moral distress resonated, often stemming from a conflict between personal values and those of employers or institutions. It can come from not being able to provide service or care that feels good enough. And it can also, linking back to Jonathan Shea's finding with veterans, can come from a sense of betrayal, being let down by those in authority, whether that's the government, through institutions, employers, and a key element, because we acknowledge that moral challenge, moral complexity, probably moral distress are inevitable in any frontline profession, I would argue. But they can become the far more serious and debilitating moral injury through lack of time and space to process, reflect, and crucially, communalize the experiences. And there is often a comorbidity with emotional exhaustion, burnout, anxiety, depression, and post-traumatic stress. So Jonathan Shea argued, and still argues, that moral repair and healing only happen in community. He has a fantastic quote where he says that two people, no matter how well trained and compassionate one of them is, two people sitting in a room are not a community. And he argues that moral injury is a social wound. The social contract has been broken, and so it needs social healing. And Brett Litzier in 2023 calls for interventions that create time and space to unburden and experience compassion. So I, myself and two other Churchill Fellows, Sophie Redlin, who's a GP and a trainee medical anthropologist, Simon Edwards, who's a military veteran and a social entrepreneur, and myself, we came together. So it's a very interdisciplinary approach. And the three of us had a Churchill Fellowship looking at moral injury through what we might call, or what might be called, an alternative lens. So even though Sophie is a GP, I'm trained as a therapist, we have this, you know, steady, hopefully sensible and reliable background. Actually, what we were drawn to was communal approaches. And Sophie's fellowship, she was immersed in and learning from Indigenous leaders in America, and Native American use of talking circles. And Simon's fellowship was at the Boulder Crest Retreat Center, which have done all the leading research on post-traumatic growth. So together, we came together and we developed this program called Reflect and Renew. We've evaluated this in partnership with the International Centre for Moral Injury, which is based at Durham University. And we had 8 participants per retreat, so it's small. And the three of us holding the space, and we because of our different backgrounds and because lots of the research had happened in a military context and emerging research for moral injury interventions in health and social care, we wanted to explore this with a mixed cohort. So we ended up having participants from really diverse backgrounds. We had a military chaplain, we had a military police officer who was involved in the evacuation of Afghanistan, overseeing things in the airport there. We had intensive care doctors, we had nurses, we had a child protection social worker. So really rich, fascinating mix of people and experiences. And the research study aimed to gain preliminary information on the effectiveness of the program, sought to understand participants' experiences with the aim of, so we're very clear, we're just gathering initial evidence with the aim of further testing this out. So the program happens, so it's in, as I said, in a rural setting, and this is really key. And when we were seeking funding for this, we were continually coming up against the answer, could you do it in a day? Could you do it in could it be a shortened version? Could it be online? And we made life very hard for ourselves, but absolutely argued that a key ingredient to this approach is that people get to fully step off the treadmill, they get to be away from home, and they are in a supportive, peer-held space where they are able to have their experiences and stories witnessed, held, with enough time and space to go as deep as people need to. So the talking circle is the structure of the program. Day one, the theme is who am I? Making sense of my experience. And who am I is in the widest sense, personally, professionally, ancestrally. So the talking circle acknowledges what we bring with us to our experiences, and how that might lead us to be morally injured, but also what strength it might give us to recover. We then move on to self-forgiveness, self-compassion, letting go of the past. And then day 3 is about post-traumatic growth and a new future. And the 3-day retreat is followed up by an ongoing community of support through WhatsApp and Zoom meetings. So in our findings, 17 respondents completed a qualitative questionnaire 1 month after the retreat. 100% found the intervention helpful. And by the intervention, I mean the retreat and the follow-up community. And 76% described it as extremely helpful. And 5 key themes emerged. So this is essentially a qualitative study. So we're seeking to really understand the approach and how effective and helpful it is. I'm not alone, unburdening and letting go, increased self-compassion, new perspective on work and the future, and greater understanding of moral injury. And really this idea of I'm not alone was the overarching finding that, and I was thinking about what was being said earlier about stigma in health and social care, and this sort of, these age-old sort of beliefs, myths that we must be strong, we must keep it in. So I think actually coming together for people across professions in a space where there was an opportunity to really be seen and heard, and crucially to witness each other. I think that was probably the most powerful ingredient. And whereas a lot of interventions for health and social care staff are offered on a one-to-one basis, or perhaps on a sort of psychoeducation, or and I know this is to do with availability, but I really believe that most of us who work in frontline professions are driven by a sense of kinship and community. Usually people would go out of their way to help a colleague, and I think that camaraderie is something that a group approach can really harness. so that this comment here was a time to empathize with my own suffering and that of others and realize that I'm not alone. And this was a real sort of story that kept coming up, that in being able to offer compassion to someone else who was sharing a painful, morally injurious experience, it became easier for people to then offer that to themselves. Once I started to speak about some difficult past experiences, I realized how much hurt I was carrying. This was a really common theme, that people maybe had come along thinking that they needed help to process one specific incident, perhaps something that had happened during the pandemic or fairly recently, and actually it became a space to reflect on and let go of the accumulation, across many years for lots of people, of challenging experiences and of moral distress. I was able to process those feelings, heal, forgive myself, and let go. One element of day 2 that's we hold very with great reverence. It's called the forgiveness circle, which Sophie has permission from an Indigenous leader to share with health and social care staff here. So that is an opportunity for people to forgive others and also forgive themselves. One of the things that we are learning across the research on, interestingly, in both burnout and moral injury, is that one of the barriers to recovery can be an inability to let go, to let things go. So while, we fully acknowledge the complexity of that and not everything needs to be forgiven, there's something, I think, really interesting there in us being able to challenge this idea of always be strong, always keep it in, and actually being able to let ourselves have space to let go. So another finding that emerged across the data was an increase in self-compassion. This person here says, when something went wrong in work in 2021, it floored me and I became my own worst critic. Since the retreat, I'm more compassionate towards myself and now see that making a mistake means that I'm human. A new perspective on work and life emerged. This person here says, I feel less defeated, disenchanted, and cynical. And I think this is really interesting. I appreciate the extent to which my sense of moral failure at work had profoundly affected my sense of myself as a person. So this is what Jonathan Shea, right at the beginning of this work, described as the undoing of character. So this sense that, when someone is exposed to or acts in a way that is against their moral compass, the effect can be global. They can see themselves as an entirely bad person, and actually having space to separate out personal, systemic, cultural responsibility can be really helpful. And the final theme that emerged was greater understanding of moral injury. Some people referred themselves to the retreat because of burnout and maybe a vague sense of resonance with this term moral injury, but actually not knowing what it was. So the evaluation showed that the psychoeducation and sharing we did around moral injury, moral distress, moral challenge was really helpful in giving people a language to understand and articulate their experiences. I think this little phrase that came from the data is so humbling. This person said, the beautiful place and the incredibly thoughtful way that everyone made us all feel comfortable, this in itself was really healing. Everyone who came, whether they were from a military, social work, some from education, health background, had unfortunately been in, as I'm sure most of us have, had experienced being in a system where they didn't feel valued and they didn't feel cared for. And I think this is a really important thing that we don't lose sight of, that actually the importance of validation and care, and somebody saying, you know what, you are worth listening to, and you're worth having a few days to reflect on the impact of your career and your work on you. So 1 year on, we met with participants on Zoom to reflect on the year and to see how, you know, how the benefits that people experienced had stayed with them. One participant had run a series of reflective days in the NHS on moral injury, cascading knowledge, creating space for more stories to be shared. Another had contributed to awareness raising within senior leadership in the RAF. Someone had set up a reflective supervision program. So we're really seeing a ripple effect there. And several participants had changed their jobs, altered, shifted things to prioritize their well-being. And the WhatsApp community, which still happens now, a couple of years on, emerged as a really helpful key element. So our aim moving forward is to develop and further test the program. I've put here integrating learning from the peer-led program in Ukraine. So Simon, one of my colleagues, he over the last year has been running a slightly adapted version of Reflect and Renew in Ukraine. They've now had, I think, 12 cohorts of military personnel and veterans, and the findings are really promising. And one of the things which we're now looking to implement is this train the trainer component. So as a follow-up to the retreat, participants will be invited to join a training supervision program to be able to embed in their workplaces semi-structured talking circles, creating regular reflective spaces which support the moral well-being of staff. And this is the absolute key, that if we want to see a preventative approach to moral injury, you know, realistically, I'm just mindful of the time, we're nearly finished. Realistically, to reduce moral injury, we need systemic change. We need, you know, huge reductions in people's workloads. We need to stop putting people into situations that force them to work against their moral compass. But we all also know that that change is going to take a long time. So to look after the moral well-being of staff in the meantime, we are really keen to work with partners to find ways of taking the essence of the talking circle approach into the workplace. Just sharing here, this is a training that I have coming up in March, because another element of change that's needed is to really increase and share understanding of what moral injury is, what a morally healthy team culture environment might look like. So if anyone's interested in that, that's coming up. And just put my contact details there. I'm really happy for these slides to be shared, if that's possible after today. And I've also got some references there. Okay, so I'm going to breathe. So I wonder if anyone might have any questions or anything that they would, like to comment on. Yes, I can definitely share the link to the training in the chat. I wonder if there are any... Sorry, I'm just struggling to see that message in full in the question there. I wonder if there are any approaches or qualities from this work you feel could be carried... Does that say, sorry, into brief interventions?
Yeah, so it says, I wonder if there are any approaches or qualities from this work that you feel could be carried into one-to-one brief interventions, or any particular cautions to doing so. Thanks, Alice.
Thank you. Yeah, great question. I think one of my reflections on working with moral injury is around, and I think for lots of us who are used to perhaps working with trauma, maybe in a more of a kind of CBT or solution focused way, there can be an eagerness to move to a resolution, you know, or to a reframing, or, you know, looking at stuck points. And I think one of the real strengths of the talking circle approach is that stories and experiences are witnessed. They're not challenged, they're not reframed. Actually, the power is in the speaker being heard. So I think perhaps that might be something that is transferable to one-to-one work. You know, I think my work with military personnel with moral injury, you know, sometimes I've noticed it myself, this sort of eagerness to, you know, help them to move out of guilt and shame, whereas actually sometimes I think what is helpful for people is to be allowed to feel guilty and shameful, and to have time and space to air that. Hope that's helpful. Oh, thank you. Thank you, Caitlin.
Thank you, Alison. I think I'll pause us there, but thank you ever so much for coming to talk to us. Diolch yn fawr iawn. Mae gennym 3 sgwrs fflach nawr a fydda'n ymddangos ymchwil sydd yn gysylltiedig â Canopi. Mae'r cyntaf o sgwrsiau gan Dr Catrin Lewis, arweinydd ymchwil ar gyfer y treil anhwylder galar hyd y môr yn y Ganolfan Genedlaethol ar gyfer iechyd meddwl. So we now have 3 slightly shorter flash talks, which will showcase research which has been in some way connected to Canopi. The first of our flash talks is by Dr Catrin Lewis, research lead for the Prolonged Grief Disorder Trial at the National Centre for Mental Health. Thank you ever so much, Catrin. I'll hand over to you.
Can you see my slides?
I can. Not quite yet in presenter mode. Yep, there we go. They are now. Yep, perfect. Thanks,
Brilliant.
Catrin.
Diolch yn fawr iawn, Naomi. So thank you very much for inviting me to speak to you today about Spring, a family of guided digital interventions for trauma-related disorders. So to give you a bit of an overview of what I'm going to discuss this afternoon, I'm going to start by checking that you know what I mean by a guided digital therapy, and I'll also outline why we need new interventions in the first place. I'll then go on to speak a little bit about the process of co-producing these interventions with people with lived experience and the core principles that underlie all these interventions. I'll then talk a little bit about the different versions of Spring. So Thomas mentioned the original version of Spring for PTSD earlier, and since then we've developed a number of different versions. So we've got a version for military veterans with PTSD, one for individuals with complex PTSD, a version for young people, and then finally a version for prolonged grief disorder. And then in terms of the intervention for prolonged grief disorder, I'm going to talk a little bit more about that and the randomised control trial that we're running at the moment in close collaboration with Canopi. So why do we need new interventions for trauma-related disorders? So we started this work a really long time ago. So we started this work in 2007, and the original development work was actually my PhD. So at that point in time, and unfortunately it hasn't changed drastically by this point in time, there were very, very long waiting lists for to receive psychological therapy for post-traumatic stress disorder. So in Cardiff, waiting lists were over a year, and you know, across Wales, you know, waits obviously vary slightly, but they were very long kind of across the board. And PTSD is a condition that is very disabling, and left untreated, it can last for many years. The good news is that psychological therapies can be very effective for the treatment of PTSD, especially those that focus on the traumatic memory itself. But unfortunately, there are a limited number of therapists that are able to deliver these interventions, and also they require about 12 to 16 hours of therapist time. So this has resulted in very long waiting times for therapy. So a possible solution is to deliver these interventions via guided digital therapy. So these involve putting the core components of the therapy onto an app or a website, and then rather than just asking someone to go away and log in and use it and support it, research kind of quite strongly says that if you incorporate regular guidance by a therapist into the mix, that really improves engagement. It keeps people going through the full length of the programme, and also improves clinical outcomes. So, you know, overall, these interventions are less time-consuming and costly to deliver, so they enable services to see more people and reduce waiting lists. So as I said, Spring PTSD was the first version that we developed. And so this work was conducted as my PhD, and we did qualitative work with people with lived experience and also experts in the field, so professional experts in the field. And we asked them, what should we include in the intervention? How should we deliver it? And how should it be guided? So we spoke to people with lived experience of PTSD one-to-one, and then we did focus groups with professional experts. We then had a prototype version of the programme, which we conducted 2 pilot tests of. So the first with 10 individuals with PTSD and the second with 9. And so that pilot work showed very promising results. And so we went on to do a feasibility randomised controlled trial, where we randomised 42 people with PTSD to receive Spring PTSD straight away, or to go onto a waiting list for 11 weeks. And that showed that kind of going on to do a bigger trial again was feasible, and also showed that it did have the potential to reduce clinical symptoms. So we then went on to do a multi-site randomised controlled trial of 196 people who were recruited across NHS in Wales, Scotland and England. And we found that Spring PTSD was non-inferior to face-to-face therapy. So there was no difference between the 2 interventions in terms of clinical efficacy. So this led to Spring PTSD being specifically recommended by the NICE guidelines. So it's one of 2 interventions for PTSD that's recommended, 2 digital interventions. And we then have done work to implement Spring PTSD across the NHS in Wales. So it's now been implemented into all 7 health boards. We've trained over 100 therapists, and we've just done a large service evaluation. So using data on the use of Spring in routine care in Wales. And we found outcomes which were equivalent to what we found in clinical trials, and also high levels of satisfaction from those who received the intervention in the NHS. So given the success of Spring PTSD, we've gone on to develop a version for military veterans with PTSD. So they present somewhat differently to people in the civilian population who have PTSD. So Spring PTSD, the original version, is designed for PTSD to a single traumatic event. And sadly, military veterans have usually been exposed to more than one traumatic event. So we felt that it needs to be adapted to meet their needs. So we got funding from the Office of Veterans Affairs, and we did work with veterans, and we asked them, how do we need to adapt Spring PTSD to make it relevant and tailored to veterans? And they came up with a number of ideas, and they felt very strongly that the colour scheme should kind of resonate with the military. They wanted army green or navy blue, which did surprise us slightly, but they wanted it to sort of look and feel relevant and tailored to them. And they also very much disliked the narrator that we had in the original version of Spring. They thought that she sounded posh and robotic, and they wanted someone with a regional accent. So we made these changes to Spring PTSD, and also added some additional content for the complex symptoms of PTSD. Content related to difficulties with relationships, self-concept, and also emotions. And we pilot tested this intervention, and we finished it last autumn. So out of the 10 participants that we recruited into the pilot study, 8 completed. 4 of these no longer met criteria for PTSD at the end, and 6 showed reliable improvement. So we were very pleased with these results. They were along the lines that you'd expect from face-to-face therapy. And also these were individuals that all screened positive for complex PTSD, and they had mostly received previous talking therapies. So they weren't the easiest group of people to treat. We've also developed a version of Spring for complex PTSD. So complex PTSD shares the same symptoms as PTSD, but also has some additional symptoms related to problems with emotions, problems in relationships, and seeing the self in a very negative way. And CPTSD is usually more associated with prolonged traumas, so things like childhood sexual abuse, or being in the military, or being in a violent relationship. And in the NHS at the moment, there aren't any evidence-based therapies for CPTSD that are routinely delivered. So there is a need for one. So we've developed this to sort of try and meet that need. So we aimed to recruit 10 participants into this pilot study, but we had a lot of interest in it. And so we had a lot of therapists that wanted to be trained up in the approach. So we had 16 therapists, and they all wanted to recruit a participant. So we ended up taking 16 participants into the pilot study. And we completed this in November last year, and we spent December analysing the data and writing it up. So 10 participants provided data on their PTSD symptoms after treatment. So we measured PTSD symptoms using the International Trauma Interview. And 90% of them showed statistically reliable improvement, and 6 of them no longer met diagnostic criteria for either CPTSD or PTSD at the end. So again, we were really pleased with these results. Of course, there was quite a large number of kind of missing data there at the end, but it was a very long intervention. This spans about 20 weeks at 16 steps. Each of the steps is much longer than Spring PTSD. So, you know, I feel that we did well to keep as many people engaged as we did. And again, these are the sorts of results you'd expect to find if you delivered this sort of therapy face-to-face. We've also developed a version of Spring for children and young people. So this is very much in line with the original version of Spring in terms of content, but we worked with a youth advisory group to inform us in terms of how we should simplify it for young people and also make it look kind of more visually appealing to them. And we also adapted all of our case studies, which we have in Spring PTSD, to be children and young people instead. So this is fully developed. We haven't started evaluating it yet, and we're waiting for approvals at the moment to do a service evaluation in Hywel Dda. And then finally, Spring PGD. So prolonged grief disorder is a relatively new diagnosis, but it has previously been known by other names such as complicated grief and traumatic grief. And it essentially involves being stuck in a state of grief. So unfortunately, all of us will lose loved ones, you know, over our lifespan. And all of us will grieve. But for the majority of people, we move beyond that period of grief and continue to live, you know, a happy and meaningful life. But for some people, about 10% of bereaved individuals, they carry on longing for the loved one and having extreme levels of emotional distress to a point where it impairs their daily functioning. And again, there aren't any evidence-based treatments for PGD available in the NHS at the moment. So we developed this to address that need. And very much the same way we have the previous versions of Spring, in that we spoke to lots of people with lived experience. We also spoke to professional experts and took what they said on board. So the resulting intervention is designed for delivery over 8 weeks. It's 8 steps and has the same pattern of guidance as Spring PTSD. So an hour of therapist guidance initially, and then half an hour each fortnight with brief phone calls in between. And so we're in the process of doing a randomised controlled trial of this intervention at the moment, funded by Health and Care Research Wales. And we've worked really closely with Canopi on this, and they've been absolutely excellent. So of the 42 participants that we aim to recruit into the study, we have ended up recruiting 22 of them from Canopi. So they've been absolutely excellent. So we had big problems recruiting participants from the NHS, because if you present to the NHS with grief-related mental health problems, you're usually offered an antidepressant, perhaps a leaflet, and then offered perhaps a referral to a third sector organisation where you might be offered some grief counselling. So it was very difficult for us to identify people with prolonged grief disorder through the NHS, and also we didn't have any therapists within the NHS who were able to deliver the intervention either. So working with Canopi has really helped us enormously. And we managed to recruit Time and Target because of them. So recruitment was completed in December 2025, and we'll be collecting the last data in April this year. And we've then got until September, when the grant ends, to analyse the data and you know, write everything up. And depending on the results, our hope then would be to go on and do a larger randomised controlled trial of this, hopefully in collaboration with Canopi. So yeah, we're very, very much looking forward to that. So in terms of our kind of future kind of plans more generally, we're hoping to continue implementing Spring across the NHS. We're working at the moment with the university to develop a spin-out company so that we can scale up all of our interventions. We're going to continue doing our evaluations of the different interventions, so pilot studies, RCTs, service evaluations as appropriate. And we're also very keen to translate and culturally adapt the Spring interventions into different languages for use in other countries. So to date, we've got a Lithuanian version of Spring, which we've pilot tested there, and we're currently doing a randomised control trial. And we'd be very, very interested in doing that in other countries as well. In addition, we've got, you know, an interest in developing new versions of Spring for other disorders or for different populations. So yeah, if you've got any ideas or want to work with us, then please do let us know. So that brings me to the end. So diolch yn fawr iawn. I'm very happy to take questions. My email address is there, and if anyone, you know, wants to get in contact and work more closely with us, then we'd very much welcome that. Any questions at all?
Diolch, Catrin, thank you ever so much. There's one from Dylan, which isn't quite at the bottom, it's just the next one up. I'll read it out in case that's helpful.
Oh, thank you.
It says, how single does single trauma need to be for clients to be suitable for spring PTSD? Is the vague question.
So I think there's difference in terms of our inclusion criteria for a trial where we're quite strict about things, and in that context, it's kind of PTSD to a single traumatic event. So in a big rapid trial, even though it was for single event trauma, the average number of traumatic events that an individual had been through was actually 5.5. So people had been through more than one trauma, but it was kind of having a primary trauma that the individual felt that their PTSD symptoms were to that. I think when it's been used kind of, in the NHS or, perhaps in Canopi as well, I guess kind of, in those contexts, it's less stringent. So I think it's directed at one trauma. So I think it's kind of very much kind of aimed at kind of doing exposure to a single traumatic event. Whereas kind of the versions we've got for complex PTSD and for military veterans, it's set up in a way where the individual is encouraged to write down all their traumatic memories and then to expose themselves to each in turn. So I don't think it's strict, and I think there is flexibility there. And Spring over the years has been used in all sorts of different ways, and we've had lots of people that have used used the program, but actually ended up writing kind of multiple trauma narratives and exposing themselves to multiple different traumas.
Thank you, Katrin. Just Jasmine, did you have your hand up? Did you want to ask a question?
Yeah, I did. Thank you. Yeah, I just want to say that was really fascinating, and it's amazing that you've been able to scale up Spring so much. My question was actually around, you were asking around different populations to trial it with. And yeah, had you considered health and social care workers as a population, because they also have unique backgrounds and needs, and it might be a really great program for them as well.
Yeah, so I mean, as part of the funding we had to make the latest version of Spring, we did add a healthcare professional to it. So one of the kind of characters case studies in the latest version of Spring is a nurse who was traumatized by working during the COVID-19 pandemic. So hopefully that does sort of target it slightly at that population. But certainly we'd be interested in sort of doing something more bespoke. Perhaps not something specifically aimed at PTSD and aimed more generally at kind of the mental health problems that are common well in the general population really. But yeah, that's an excellent idea, and certainly something that I think is worth thinking about.
Yeah.
Thank you, Jasmine, for that question. We're going to come on to you very shortly. I'm just going to well, I might just answer this actually question from Rebecca in the chat, which was, would anybody accessing need a diagnosis of PTSD prior to accessing via Canopi? No, everybody that comes into Canopi has an appointment with one of our doctor advisors, and they would have a conversation with them about the things that happened and the symptoms that they were experiencing. And if there was a feeling that there were some symptoms of PTSD, then they would potentially go on further to have a wider assessment with a therapist. So they don't need to have already got a diagnosis to have support for us via that option. Great. Well, diolch yn fawr iawn, Catrin. Thank you ever so much for joining us today. Much appreciated. So, symudwn ymlaen ac ei sgwrs gan Jasmine Lang, arweinydd ymchwil ar gyffedd Trial Shape yn Prifysgol Rhydychen. So, we're very grateful to have Jasmine Lang, lead researcher for supporting healthcare and paramedic employees, a SHAPE intervention trial at the University of Oxford. Join us now and I'll hand over to you. Thanks ever so much, Jasmine.
Thank you, Naomi. I really appreciate it. And yeah, can I also just check that people can see my slides?
Yeah, I can.
Okay.
Thanks.
Great, thank you. Well, first of all, I just wanted to say it's a real pleasure to be able to present my research at this symposium. So thank you so much for the invitation. And actually, this will be the first time that I am presenting the findings from the trial that we ran on the SHAPE intervention. So I think it's really special, particularly because, just like Katrin had mentioned, Canopi has been a really massive help in the trial. So I think it's a really nice way that, the first people to hear about it is at the symposium. So yeah, my body of research is really focused on health and social care workers and improving the mental health outcomes for this population. And so the SHAPE intervention is basically an intervention that has been tailored by my research team to basically support this population more specifically. So I just wanted to give you a brief kind of overview of some of the realities of health and social care workers. So we found from research that health and social care staff are known to be in a higher risk population for developing common mental disorders. There's been a number of really high quality research studies that have documented that health and social care professions have a higher risk of developing common mental disorders such as depression, anxiety, PTSD. And this can be down to some of these unique factors, which I think the speakers ahead of me have done a really wonderful job in illustrating. But just to kind of, again, give you a snapshot of what some of those are, we've got this kind of intersection between occupational factors, thinking about things like longer shifts in other professions, working in these high stakes environments, being much more exposed to morbidity and mortality on a daily basis. We've also got the individual factors, so thinking about the compounding of existing mental health problems, existing external life stresses, which we are all not immune to. And then also, there's also been some really good research that's been conducted that has looked into specific cognitive risk factors that are appearing to be higher in health and social care workers or subgroups and such. One example being higher rumination in paramedics, a study has found. And this, we know now that rumination is not only a mechanism in the maintenance, but also in the kind of onset of several mental health disorders, such as depression, but also PTSD. We've also got these social factors, so thinking about bullying and harassment that occur within workplaces, which has been cited quite a lot in health and social care settings, discrimination, and then also, like the speakers have been speaking about, stigma and stereotypes around mental health and disclosing mental health illness and, coming out and seeking support. And then finally, we've got these, organizational factors, which I think are quite pertinent in the United Kingdom, particularly around this idea of shorter staffing, which then has that knock-on impact to higher caseloads for the staff that are still remaining and left to take on those additional patients. But then also these financial pressures that we are seeing very commonly on the news about the pay not being where it should be, and not in line with inflation for many different professions in health and social care. So just thinking about all of these factors kind of compounded together, it makes sense that health and social care staff have this high risk of developing mental health disorders. And the thing that I guess the problem about that is that although we have found that there is this high risk of mental health disorders in this population, there's been a number of research that's actually found that treatment seeking still appears to be low in health and social care staff. And again, some of the reasons have been really beautifully illustrated already in this symposium, but thinking about things like stigma, time and practicality constraints, and just not having enough time to access the care. If you're thinking about these really long shifts, not having the energy or the time at the end to access the care. But then also confidentiality concerns and kind of thinking about that a lot of the time the support is offered within workplaces, and sometimes that just might not be something that people would like to take up. They would like it to be a bit more separate from their work. So there seems to be this gap between service provision and service uptake in this population. And I think this really raises the question as to whether the current mental health support available is acceptable and accessible for this unique population. So that's where I guess my research team comes in, and like I mentioned, they developed an intervention called SHAPE, which stands for Supporting Healthcare and Paramedic Employees. But over the years, it's since evolved to also kind of accommodate social care workers under this umbrella term. But we've struggled to find a way of kind of incorporating social care into the title, but it is definitely open to both health and social care professions. And basically what SHAPE is that it's a brief coaching intervention for both PTSD and also depression in this population, and it's very much designed around these realities of shift work, time pressures, and confidentiality concerns that health and social care workers face. And one of the ways that it can kind of overcome some of these barriers, we hope, is that it is delivered remotely. So that will hopefully improve both the accessibility of it, but then also the confidentiality of the care being received. And it incorporates this use of kind of practical evidence-based cognitive therapy tools to really try to target some of these core symptoms that we found in research are higher in health and social care workers. So what exactly SHAPE involves is, as I mentioned, it's a short structured program, and it's typically between 6 to 8 coaching sessions in length, which, as you've probably now noticed, is a lot shorter than kind of traditional high quality interventions that are currently on offer and being rolled out in the UK. It's also a coaching format, so we've also kind of tried to steer away from words such as therapy and things like that, and adopted the kind of terminology of coaching and having a coach to hopefully, again, make it a bit more accessible if you're thinking about things like stigma. It has these practical tools and also these in-between session practices and online modules that we've developed with PPIE for service users to use between sessions if they would like. And as I mentioned, it targets these unique processes that have been researched to really kind of maintain PTSD and depression, such as rumination. So as you can see with this image here, these are some of the core tools that are used in SHAPE, a lot of which have been adopted from already high evidence-based therapies such as cognitive therapy for PTSD. And they're all kind of targeting these different unique symptoms that we've found. And I guess I just wanted to actually point out that one of the tools is surveys. And I think as Alison spoke about this idea of this community aspect, we've definitely found that surveys are really, really powerful in starting to shift some of these beliefs that people might have around shame, blame, guilt, and the like. So in terms of how it's delivered, as I've mentioned, it's completely remote. So that can be either on a phone call or over Microsoft Teams. And it's also been delivered by a wide range of trained professionals. So we found in our research that PWPs, psychology graduates, counsellors, and also clinical psychologists can deliver SHAPE with very similar rates of efficacy, which is really wonderful. And it's also very adaptable to preferences. So it can be adaptable to having the camera on or off, and also kind of session number and length as well. So in terms of what we've kind of begun to find in terms of evaluation of SHAPE, SHAPE was initially evaluated in a pilot study during the pandemic. So between 2020 to 2022, and the sample comprised of 103 healthcare workers at the time. And it found very high rates of recovery from both PTSD and depression. So yeah, 77.1% from PTSD post-treatment and 64.3% for depression. So you can see that it's got very similar rates of efficacy for both disorders, which I think is really wonderful to see. And actually the paper for this study has actually very recently been published. So if you're really interested to learn more about the pilot study, you can access that there. But basically what the pilot study found was that it warranted a randomized control trial because the rates were so good. And that's kind of where I come in. So a large proportion of my PhD has been running this randomized control trial on SHAPE. And we wanted to compare SHAPE, people who receive SHAPE in an intervention condition to waitlist conditions, so people that didn't receive anything at all to begin with. However, they were also given the option afterward to receive SHAPE. So everyone got the opportunity to have it. And the kind of primary kind of time point was 8 weeks. So 8 weeks post-randomization, we conducted a SCID-5 diagnostic assessment, and we compared the rates of PTSD and depression in both of the conditions. And we predicted that SHAPE would be superior to the waitlist condition. And overall in the trial, 94 health and social care staff took part in the UK, and the trial has very recently concluded. So we finished all of our data collection, including our 6-month follow-up in December last year. And yeah, and now we've kind of got to the stage where we've conducted all of the main analyses and are just about to start the 6-month analyses for follow-up. So in terms of, I guess, just wanting to again come back to Canopi and just say thank you again. I just wanted to point out that we were we got in contact with Canopi kind of halfway through the trial, maybe, or maybe a third of the way through. And they've been really amazing in bolstering our recruitment rates. So you can see that 76 referrals were made into the trial by Canopi, and of those 76, 54 were eligible and took part in the trial. So over half of our sample came from Canopi. And I again just wanted to express my gratitude for the support that we had from Canopi in making this possible. So what did we find in the RCT? And as I mentioned, this is the first time I'm kind of showing these findings. So we found that the SHAPE group showed significantly higher rates of reliable recovery at 8 weeks compared to the waitlist condition. And in fact, we found that being in the SHAPE group reduced the odds of still meeting criteria for PTSD and or depression by about 98%. So really high rates compared to the waitlist group. And in terms of what that kind of looks like, it's around for every 1 to 2 people that receive SHAPE, one person will lose the disorders that they came into. So PTSD, depression, or both, depending how many disorders they came into the trial with. So really promising findings. And I guess to just zoom in a little bit more, we found that in terms of recovery rates from PTSD and depression, 84.8% recovery rate in the SHAPE condition compared to only a 13.5% recovery rate in the waitlist condition, which you can just see as well illustrated in this chart. So SHAPE being the orange group came down to 10 people at the end having either PTSD or depression by 8 weeks, compared to 40 people in the waitlist control condition. And I guess just looking at the findings a little bit differently, we found, thinking about people having both disorders by the end, that only one person in the SHAPE condition had both disorders, compared to 21 in the waitlist condition. I will mention that this was a complete case analysis, so people that had missing data were not included in this figure that you're looking at. And again, if you wanted to see, broken up by PTSD and depression, we've got the PCL5 looking at PTSD and the PHQ-9 for depression. And again, you can see that the SHAPE group came well below clinical cutoff rates for these two measures compared to the waitlist group, not crossing underneath that threshold. So I guess also what I wanted to do during the trial was to take a wider kind of approach and also look at the kind of qualitative feedback from people that had the intervention. And so I also conducted a qualitative study whereby I interviewed participants and coaches that delivered the SHAPE intervention and really kind of asked questions around the acceptability of SHAPE, the accessibility of SHAPE, the suitability of SHAPE, but also what worked and what didn't work. And I guess I just want to mention that I purposefully sampled my participants for this study. So I wasn't only sampling and inviting participants that did, really well, but I was also making sure to, interview people that maybe didn't lose a diagnosis or 2 diagnoses. And what I found was actually there was this overwhelming positivity around the intervention, and people really, really liked the intervention. They found that it was very acceptable, it was accessible, and it was suitable. There were, of course, a few recommendations and improvements, which we would expect. But I think in the big scheme of things, these appeared quite manageable. So things like people preferring maybe remote, face-to-face, over remote, or people wanting to have cameras off instead of on, or, a change in session number. But I think everybody basically recommended SHAPE to a colleague, which was, I think, really encouraging for us to hear that from people. And you can just see some of these quotes. I can just read out a couple, but someone said, "I found it hugely helpful, probably the most helpful and kind of psychological intervention I've done. Yeah, it already made a big difference to me." And another person said, "So it's been really helpful for me, and I think a lot of people can benefit from it. This was really specific. Coach could understand me in my work and the sorts of things I have to deal with." So yeah, I guess I just wanted to say in terms of the reach and scalability of SHAPE, so far we've delivered it to over 200 health and social care staff across the United Kingdom. We found now with these 2 different studies that there is strong evidence which supports the rollout of SHAPE. And we've also found that it is feasible to scale because it's briefer than kind of traditional therapies for PTSD and depression, but it can also be delivered by this wider workforce as well. And it addresses both PTSD and depression together. So it's kind of like, you know, a one-stop shop for two different disorders, as opposed to the one. So I guess, yeah, two for the price of one in a shorter kind of length of time. And I think that hopefully really fits with health and social care staff just not having a lot of time to take up an extended length of coaching. So I guess just to end, in terms of what happens next, there's kind of two practical next steps that we have in our minds in terms of rollout. The first one being that we would like to have a bit more of an investment in updating and expanding the online resources and intervention users. And this has been based on feedback that we received. And we kind of already predicted that was going to be the case in just terms of modernizing the online resources, but also receiving a bit more funding to train up more clinical psychologists and clinical supervisors to oversee the supervision of shape coaches, because I think that's a really integral part as well of the intervention and making it so effective. And I guess just kind of going back to, I guess, what the Minister of Mental Health, Sarah Murphy, said, but I think she really beautifully articulated it, that, you know, it's just really, we believe it's really important to invest in health and social care workers and look at them as a unique population. And we found that by doing that, you know, you're not only improving their mental health, but you're improving the services that they work within, you know, you're improving recruitment and retainment of these people, but then you're also improving their service users' experiences as well and having a knock-on impact to their patients that they treat. So yeah, thank you so much for listening. And if anyone has any questions as well, you can either ask now, or I've included my own email address and the PI for the trial, Jennifer's here, as well as just a couple of studies that was recently published if you'd like to find out more about the SHAPE intervention. Thank you so much.
Jasmine, thank you ever so much. Great to hear about the results, and yeah, I know Canopi's been grateful to be able to help both yours trial and the SHAPE trials. So we have a question in the chat, but I think it's a little bit more of a kind of a general Canopi question, which I think is probably best to pick up at the very end if there is time there. Does anybody have any questions for Jasmine? If there aren't any immediately, if there any come to mind, we can always maybe pick those up as well at the end if there's time. Just pause for one more minute, just in case anything pops in that I haven't yet seen. There's one just come in. Thank you, Bex. Did you find any differences in both delivery and access for social care?
Yeah, I think that's a really great question, and I'm actually quite glad that you asked that, because we, not so much in terms of delivery and access, but we found that there was significantly less social care workers that took part in the trial. And which I guess is interesting, because Canopi being a service both for health and social care workers, and a service that a lot of our participants came into the trial through, there was very little social care workers that took part in having the intervention. In fact, there was 8 overall out of our total sample of 94. And we really tried to, you know, utilize different recruitment routes to access these social care staff. They did do, I think, equally as well. I haven't done an analysis yet to look into exact differences, but just eyeballing the data, they did very similarly to healthcare workers. But yeah, I think that's actually quite an interesting, it's something that I'm still thinking about, because other studies I've conducted as well, it's been harder to reach social care staff. And I don't know if anyone actually has any insights into that, but if you do, I'd be really interested to hear that, because that was definitely a sticking point for us in terms of reaching that population, which was unfortunate.
Thank you, Jasmine.
Thank you, Rebecca.
Yeah, Rebecca will get on in touch. Great. Thank you very much. I'm going to move us forwards, but thank you very much. Bydd y sgwrs olaf gan athro Neil Harrison ac ar ôl hynny, oh no, I won't go on to say that. I'll just say, yeah, our final talk will be given by Professor Neil Harrison. Neil Harrison is a clinical and commercial director at Kubrick, co-director of the Hodge Centre for Translational Neuroscience, and a research lead for the Cardiff Immunopsychiatry Research Group. I'm hoping that your slides are up, Neil, so I'm hoping you're all good to go. Thanks very much.
Yeah, thank you very much, Naomi, and thanks very much for the invitation to talk. Can you hear me okay? That's the first question. Yeah.
Yes, I can. Thank you.
Great. Okay. I'm currently up in North Wales because there's an MRC meeting here, but I popped out. Look, yeah, so I know I'm the last speaker, so I'm going to talk a little bit, or I've been asked to talk a little bit about what's next for mental health research. And I know a fair bit of the focus has been on sort of psychological therapies. I very much come from much more sort of biological sort of background. So I'm going to take you on a bit of a journey in the next sort of 15, 20 minutes, just to say, you know, where I think some of the challenges are, and end with what I hope will be some of the solutions that we can put in place doing our part in Wales. So what's next for mental health research? So first off, where are we at the moment? And this is a quote from Tom Insel. And Tom Insel was head of the National Institutes for Mental Health in the US, based in Bethesda for 13 years. And you can see what he's written here. You know, he's been there. He's really pushed for the neuroscience and genetics of mental disorders, really pushing some really fantastic science. But basically what he said at the end of this journey is that, you know, we've published a lot of fantastic papers, we've perhaps got some new insights into this, but really, have we changed the dial whatsoever for patients who are experiencing some of our most severe mental illnesses? And his position was, well, no, really, we're not changing the dial. And that corresponds with sort of a wider understanding in the field, is that really there are almost no mechanistically novel drug therapies in psychiatry since the 1950s. There are perhaps one or two exceptions to that in the last year or two, but really we're way behind other areas of physical health in that we're really not designing new therapies. And just to push that case home a little bit more, I mean, this was an opinion of Tom Insel, who led up the biggest mental health research center in the US. This is an opinion piece from somebody called David Nutt, who I imagine a few people in the audience will have heard of. David was, he's a psychiatrist. He's a British psychiatrist, actually lives in Bristol, but works at Imperial. And David was, under the last Labour government, was the drug czar. Advising on the use of recreational drugs. But essentially, I mean, he's making exactly the same point. Over the last 50 years, medicine has advanced enormously. You only need to think of treatments for diabetes or rheumatoid arthritis or any of these other conditions. But really, at least in the biomedical space, we're not making an awful lot of progress, if any at all, in developing new treatments for our patients and our service users, despite the fact that, you know, incidence and prevalence cases rates are rising. And that isn't through lack of trying. There's been billions and billions of dollars have been spent on drug discovery efforts based on lots of new neuroscience targets, and yet still we don't have any new therapies. So where are we today then? I mean, if you wanted to sum it up, you know, half a century after Prozac, we're still prescribing the same medicines that target the same three neurotransmitters, serotonin, dopamine, and norepinephrine, that we did, you know, half a century ago. And that's despite all of this money that's being spent. So why are we stuck here? You know, briefly, what is the diagnosis? And then we'll perhaps look a bit about what we're doing to try and shift the dial on this locally. So I think we're probably all understanding now that the categories that we use to diagnose our service users, our patients, are quite broad, and they're probably far too heterogeneous. So, you know, if somebody presents to clinic with depression, each person that presents will have a slightly different presentation to another. So there are, and if you look at the diagnostic criteria, there's more than 200 different ways you can present different symptoms you experience: eating too much, eating too little, you know, finding that your mood is down and you're not sleeping, etc., etc. And yet our treatments, though everybody in all of these, you know, different presentations gets the same diagnosis and the same treatment. So the big question here is, these are all completely different symptoms. Are they really the same underlying pathology? Are we, you know, is the problem the reason we're not progressing just because we're lumping everybody together and not thinking about how people are different? And Mike Owen, many people may know Mike. He was the previous head of division here in Cardiff and has been, well, Sir Michael Owen. He has really done an enormous amount in pushing forward global understanding of the genetics of severe mental illnesses, particularly schizophrenia. And really his his point is that if you look at the biology, if you look at the genetics, it doesn't really correspond to the diagnostic categories we're using. So if we identified, say, somebody has a diagnosis of schizophrenia, and somebody else has a diagnosis of bipolar disorder, you can't differentiate these conditions just on the basis of genetics alone. So again, there are some severe problems with our diagnostic categories. They're the best that we've got at the moment, but they're clearly not helping and perhaps are even hindering the development of new treatments for some of our patients. The final point, I mean, this is a very nice review paper, again, looking at the position from a slightly different angle, and that is that unlike most parts of medicine, we don't have biomarkers in psychiatry. So if you think, if you go to a GP because and you get diagnosed with diabetes, that's normally on the basis of a test that looks at blood glucose. Many other tests like asthma, diagnoses like asthma, you'll look at how your lungs respond to a task. But in psychiatry, we have one biomarker, and that is body mass index for diagnosing anorexia. Apart from that, we don't have any biomarkers at all. So again, really stifling abilities to develop new medicines. All right, so that's the bad bit. That's where we're at. There's a little bit of a diagnosis about perhaps why we're here, but what are we doing within Wales to try and move the dial? And I just want to tell you about 3 different approaches that we're taking at the moment at different levels of tackling some of these, what are clearly very difficult and global problems. So the first one is something called the Brain and Genomics Hub, and this is a large MRC funded or UKRI funded project that I'm co-leading with James Walters, one of the professors of psychiatry here in Cardiff, but we're collaborating across all of our partners in the Southwest, so Swansea, Bristol, Bath and Exeter, and really, if you like, using the combined expertise and skills of academics and clinical academics across the whole of the Southwest. But the position here is the one I've already pushed out and explained, is despite all of this work, our mechanistic understanding of some of our most severe mental illnesses is really quite poor. Diagnosis is probably a barrier to research, where we don't really know how to diagnose patients, and there just haven't been any new drugs. So what we're doing, and we started this project last year, is to build what we would term probably the most advanced, deeply phenotyped cohort of people with severe mental illness in the world. And I know this is hyperbole, but other groups have attempted this, particularly within the US, but this is going to be taking a large group of people with severe mental illnesses, 600 is what we're aiming for in total, and bringing them into the clinic. We're working with various charity groups here, so Bipolar UK and Adferiad within Wales, to collect a whole lot of brain imaging with MRI, electrophysiology, so something called MEG, which is, if you like, a sophisticated way of doing EEG, doing genetics, doing blood sampling, doing very comprehensive cognitive tests and clinical profiling, and then linking everybody to their health records, so we can look backwards in time, look at any developmental difficulties individuals may have had, and also we can look forward in time. And the whole aim of this is really to go back to basics, if you like, and think, can we redesign categories and classifications of people with these severe mental illnesses that are based on biology rather than based on a collection of symptoms? So this is how we're doing it. We're going to collect this really very large cohort. So we started this in May last year, and we've already recruited 125 people. The responses here have been fantastic, and the BBC has been very helpful in promoting this study. And people have generally really responded well to taking part in the study. There's an amazing team of six research assistants who are really walking people through what is a pretty complicated day, if I'm honest, jumping into MRI scanners, doing cognitive tests, having a bit of lunch, and then finishing the MEG and some of the other questionnaires. But the plan is we're going to be working with AI, machine learning experts, both locally within Cardiff, but also within Warwick. There's some mathematicians in Warwick who've designed new ways of trying to cluster people on the basis of all this data to what would be slightly more homogeneous groups that may clarify to us what the biology is underlying some of these individual clusters. Anyway, this is an enormous piece of work, and one of the reasons I wanted to highlight it here is really, any support we can have in continuing to recruit and refer patients to to this would be extremely appreciated. So the second area that I just wanted to focus on is clinical trials, and this is a real success story for Cardiff and South Wales more broadly. But the National Institutes of Health have identified one of the key reasons that we're not being able to design new medicines is oftentimes we don't even have any way of knowing whether these medicines are doing anything in the brain in humans. So this is something called target engagement. So oftentimes new medicines will be taken through phase 1, phase 2, phase 3 trials, and each phase of these trials gets more and more expensive. Phase 1 is about 5 million, phase 2 maybe 20 to 30, and then phase 3 probably looking at $300 million plus. And what's happening is that these drugs are failing at this very expensive end stage. So what we've done, working together with some colleagues in the Medicines Discovery Institute in Cardiff, was find a way of de-risking this. So what we've done is we've incorporated brain imaging measures of what's called target engagement, i.e. just trying to see, do these drugs do anything at all in healthy volunteers in order to either rule out that medicine for further clinical trials or to select it to move forward. And I think, as you can see on this slide here, this has been very successful on the first drug that we did this for. So last year, there was an enormous spin out called Drive Therapeutics out of Cardiff. It's been Cardiff University's biggest ever spin out, $140 million. This is the article on it. You can see it was from June in the Financial Times. There were also coverage of this in The Economist and various other journals. Really demonstrating the value of taking a fresh new approach that we've been able to do here in Cardiff. And we hope that this is something we can work with other partners like Simbeck Orion, who we're very lucky to have as a contract research organisation in Merthyr Tydfil, to carry on this sort of work to try and accelerate the speed at which promising new medicines can make it through into clinical trials. So the final thing I wanted to do just towards the end of my talk here is just talk about moving to a slightly different level, is to talk about a new clinic that we set up. We set this up at the end of last year, and it's part of a UK-wide network of what are called research-ready clinics. So, and this has been funded by the Office of Life Sciences, so this is UK government funding, to set up this network of clinics, because what's been observed is that there are very, very many patients out there who are in primary care who are perhaps not getting better. They've tried 2 or 3 different medicines in primary care. Their depression is not getting better, but they're perhaps not quite severe enough or have a high enough risk profile to end up into secondary care services. So they've been termed by a number of groups this sort of missing middle, if you like, patients who are just not getting better, but aren't able to access specialist services. And these are exactly the type of people that clinical trials are looking for, people who are not getting better with conventional medicines, but may get better with some of these new approaches. And I'm not just talking medicines here. As part of this network, there are groups, for example, in Exeter, who are doing trials of psychological therapies. We're currently starting a couple of trials of some wearable devices, and there are a large number of sites that are looking at new medications. But as you can see here with a big arrow, Cardiff is one of the 15 sites as part of this network. We launched at the end of last year. We're currently taking referrals from the Cardiff and Vale catchment area towards this clinic, where patients will get a specialist assessment, recommendations to general practitioners, and if we have studies available that would potentially fit their condition, then we can tell them about those trials and they can consider whether they want to take part or not. So just a little bit more about the clinic. I mean, this is a collaboration between the university and the health board, Cardiff and Vale. We've called the clinic the Care Clinic. A clinical assessment for resistant depression is the acronym perhaps didn't quite fit, but we had some user input into here, some PPI input, and that was felt that this was a nice name to give the clinic. We're working also in collaboration with Cardiff Metropolitan University, so that's Diana Crone that you can see here. And Diana has done some very interesting work on social prescribing and exercise therapies, and Diana, anyone seen in this clinic will have the opportunity to be referred to Diana and her team, who can then discuss potential sort of third sector input or social prescribing sort of input here. So this is the final slide. If you're interested in knowing more, if you search for the Care Clinic, the Cardiff Care Clinic, we're based here. We're based on Maindy Road in this building, you know, the orange-coloured building behind the slats there. We're currently running clinics every Tuesday, but we plan to expand that to 2 days a week, where people get a comprehensive assessment and then recommendations back to primary care. So I'm going to stop it there. Thank you very much for your attention, and I'm very happy to take any questions. Thank you.
Diolch yn fawr, Neil. Thank you very much. I'll just pause a minute and see if there are any questions, but that was a fascinating journey through lots of different areas of things linked to Cardiff, so that's great. Just pause briefly and see, has anybody got any questions that they'd like to ask Neil? I'm aware that we're heading towards our originally advertised end time, so we will... oh, there's one from Thomas. He says, is the clinic to support people with mood disorders only? Mixed presentations, how are they managed?
Yeah, that's right. It is, I mean, at the moment, it is people with mood disorders. So that can be unipolar and bipolar depression. At the moment, it's designed as an assessment service. So we can offer 1 and possibly 2 follow-ups, but it is very much a research clinic. So we don't have an enormous, group of staff that can provide support, supervision, out of hours sort of follow-up and things. So there are criteria about risk that we need to consider. So we can't, the most challenging people we just can't take on in this clinic, because we wouldn't be able to feedback on risk. But the plan is, yeah, we'll provide, a high quality secondary care sort of assessment, recommendations to GP. If some of the recommendations GPs may want a little bit of support implementing, so we will arrange sort of 6-week and 12-week follow-up, so we can see, how people are getting and offer advice for tweaking interventions if that's needed.
Thanks, Thomas, for that, and thanks, Neil. Just heading on down. I can't see any other questions. I wonder, Thomas, whether we could come very briefly to you. I think Michael asked a question earlier about the mechanisms, or what mechanisms are needed between Welsh Government, Cardiff University and health boards to ensure that insights from Canopi translate into structural change, particularly around staffing pressures, psychological safety and retention.
Thank you, Naomi. I think it's important just to point out, thank you to Steve Craddock, who's put a note from a note into the chat as well. So he said Canopi, our Welsh Government partners, who Steve represents here, will continue to work with Canopi to share the notes and presentations of the finding of today with colleagues in Welsh Government. So I think the answer to Michael's question is multifactorial. So this as a symposium is a mechanism for us making sure that we're feeding back, as Steve will support us in doing so. And then in terms of other mechanisms for feedback, we have regular meetings with our Welsh Government partners to go through the performance, but also the ideas, challenges and expectations, I guess, of the Canopi service, the things that we are working through and challenged over. So that's one mechanism. And then just to make sure that we're reflecting the broader sense of the service back then when we do our larger data collections and data analysis events from a Canopi service, then that data is also fed back into Welsh Government as a funder. The conversations around what we do with that data are really important for us as a population, aren't they? And I guess that remains a challenge for us across not just healthcare, but other employment sectors as well, about how we support people to reflect, grow, be educated in, be supported through psychological challenges, staffing pressures, etc. So I think it's important to say that we don't think collectively that this is unique to health and social care. Not to say that it isn't a problem in health and social care, but we do try and make sure that we've shared that data as we're able to with Welsh Government and other partners across Wales and broader than that. So hopefully that answers some of Michael's question. and thanks for the opportunity to pick that up.
Thanks, Thomas. Being aware of time, I am going to bring us to a close, but if anybody does have any questions or anything that they'd like to pop in the chat afterwards, we can always pick those up. But I just wanted to end with diolch yn fawr iawn i'r siaradwr heddiw a diolch I chi am ymuno ar y symposium eleni. Thank you ever so much to all of our speakers today. We're very grateful for you coming to speak to us, and thank you ever so much to everybody who was able to join, and hope you found it interesting and helpful. We will be planning to send out a short evaluation form to everybody that joined. If you're able to share your thoughts on the afternoon, we'd be very grateful. But thank you again ever so much for joining.